All right. I'm Rodney Whitlock. This is a slot I get somewhat regularly, apparently, that I'm the only thing between you and happy hours or airplanes. So I'd like to say thank you for having me. Enjoy the rest of your day. Um, um, so I was a Hill staffer for 21 years. I'm extraordinarily happy not to be there anymore, having retired in 2015, and I'm fairly comfortable. I can find people there who are extraordinarily happy I'm not there anymore. And so since we have this love relationship, I'll bring from that to tell you how the Hill interacts with this subject. From my perspective and my experiences, as someone who started on the Hill when there was HICFA and no such thing as SGR, and somebody who retired from the Hill when it was CMS and no such thing as SGR. Which I think there are only like one or two people up there who could say that, now having been there continuously through the SGR years. Which does speak to the importance of the role that the Hill plays. The Hill makes the policy. SGR was created by some yahoos that we all know, who I won't name out loud. But, oh, am I being taped? I hate when that happens. So, listen, the Hill determines policy. Who? All the people up there. Okay? And so we can sit around and say things like this. And this is something I believe, and I've said so in published work, which is, I think if you want to change the nature of the provision of health care, you need to apply continuum of care models, hangnail to hospice, cough to coffin, that use risk-bearing entities to deliver the care, which will then create an ideal alignment to produce optimal outcomes. Okay? That's what I think. Now, we have a system that is horribly misaligned and produces outcomes that drive us insane every day. And we know that. We watch it every day. It's the octogenarian couple in the doctor's office. The doctor sees a husband deep with Alzheimer's, a wife putting herself in the grave, keeping him up, and Medicare sees clean claim. And that's it. And it drives us all nuts to deal with it. So let's change it. But let's talk about what we have to deal with to change it. Because public policy is not clicking our heels 3 times together and thinking we're going to do anything but end up in Kansas. Okay? You actually have to go through the process of, I'm just a bill. Yes, I'm only a bill. And I'm sitting here on Capitol Hill. Think about that. You have to go through that to get a law done. There are 535 offices, all of them trying to understand healthcare. And very few of them have the ability to specialize at a level that comes remotely close to understanding anything that's going on in this room. That's not to denigrate the hardworking young people that are up there. But they got a lot on their plates, and they don't get to specialize. Only a handful of people do. And then you have to have the correct alignment of stars that cause people, not the star system, but cause people to actually move in the direction of making policy change, when at a fundamental level, the philosophical underpinnings that drive them are extraordinarily different. On one side, you have a group that believes that if you emphasize getting people covered, above all, move then to ensure that the quality of that care is as high as it can possibly be, ultimately, cost will solve itself. And on the other side, you have a group who looks at the same issues and says, cost is paramount beyond all doubt. We must control cost by any means necessary. If we can pick up quality along the way, that's good, and ultimately coverage will happen at the end of the day. When you have so two diametrically opposed views of their approach to healthcare, finding the common ground for conversation is extraordinarily difficult, especially when you head into this space where the first time you start to try to address this, you immediately trot out the political. And that is, well, wait. You're messing with Medicare as we know it. Oh, you can't do that. You can't. Everybody is waiting at any given second. Oh, you cut Medicare. You're destroying Medicare as we know it. And let's go run off and scare people who are aged and run ads and try to win elections rather than actually solve a freaking problem. That's what we do on a regular basis in the political realm that has to produce the policy that is ultimately what we're talking about today. Thankfully, we have seen opportunities to look at it differently. The Affordable Care Act created something called CMMI. And CMMI created opportunities that the Hill could never take. Now, I can tell you, as a longtime Hill staffer, the concept of CMMI was incredibly offensive. I disliked what Patrick did regularly. And it's not anti-Patrick, but the Affordable Care Act essentially granted CMMI and our good friend at the other end of the table omniscience and omnipotence. You can create whatever you want, and if you think it's right, you can move forward with that. Now, from the Hill's perspective, where we thought we wrote the laws, having that authority vested in an administration without our ability to say, whoa, wait, what? Is extraordinarily offensive. And if the administration came to me today and asked me if I'd like to succeed him, I'd have to think about that. Because if you got to invest in me omniscience and omnipotence, I could have some fun. I'd love to have that authority in my household.
The job is still open, as far as that.
Yes, for obvious reasons. Like I said, I'd love to be vested with that authority in my own household. But an example of where we saw that, and it shows, frankly, the extreme differences between the way it can be viewed in a CMMI role and in a congressional role. One of the things I had the joy of working on was something called the Diabetes Prevention Program. Okay? And I believe that the concept of diabetes prevention and the mechanisms for using it are appropriate public policy. I believed in it, worked on it for Senator Grassley. He was the lead for that. And from a congressional standpoint, we worked to try to move that, gain co-sponsors, doing our job in the I'm just a bill world. Okay? And the diabetes prevention program is now actively being implemented in the Medicare program, thanks to all of our hard work in getting it into law, getting it signed, getting it the votes on the House and Senate floor, and passing it into law, right? No. You know, himself over there with a capital H is how this got to be in law. Why? Because CMMI had the authority to do so. CMMI looked at it and said, yep, we think so, we're going to take it live, and we're going to take it national. Do you know what CBO did to us on the Hill when we tried to do that? I almost should have it on my device handy because I had to make the case to somebody else recently of this point, which is CBO, who governs the Hill, told us that, nope, not in a million years. It will cost money, it will cost billions of dollars, tens of billions of dollars to put this in. And in fact, we'll show you that if you're overweight, it doesn't make a difference. You can go up, you can go down. If you're in that sector of overweight, not obese 1, obese 2. If you're in just plain overweight, doesn't matter. Your healthcare costs don't change. Here's our data. Have a nice day. So just crushed us in the legislative effort. Now, Patrick, on the other hand, he could say, I think this works. Law. Gotta tell you, I'm reconsidering this whole thing about how much I'd like CMMI here. But it shows you the challenge, okay? That to achieve public policy ends, even when we know we are right, even when we think that we are doing the right thing, that the complications that face us are extraordinarily difficult. Not the least of which is the Congressional Budget Office that we deal with. My old boss, Chuck Grassley, had this overstated belief that CBO is God on the Hill. And my corollary to that was, yeah, but you know, at any day we want, we can declare ourselves atheists for the day. We can walk away from CBO and say, we actually choose not to believe you today. We choose not to do what you think. We choose to do something because we think it's actually good public policy. But that's extraordinarily rare on the Hill. I mean, after all, the only reason I got to say that I was on the Hill before and after SGR is because after 15 years of dealing with that shit, finally, Congress looked at each other and said, you know what, we're going to take a mulligan here. We're just going to take a $150 billion mulligan. CBO put it on sale. We're going to take it and say it didn't happen. We were drinking when we started this. So we're going to take a mulligan here. See, this is why I get the in slot, because I might say outrageous thing that causes you to be awake. So our challenge moving forward, and for those of us who care about this space and know that doing the same thing over and over again and expecting a different result is commonly attributed to Einstein as a, quote, defining insanity. And that's what we do in healthcare so often. And we all know we need different models. So somewhere between the private sector efforts and the public sector efforts, you have to deliver to us who work on the policy side, and I'll take that now as the us from the, I worked to lobby the Hill and spent all day on the Hill lobbying the Hill, that if you want to get the Hill to look at things differently, it has to be so overwhelming that they're willing to take on the role of, today we're going to be atheists and we're going to do what's right because we believe that. And that's the challenge we face in making policy, and particularly the chronic care space and dealing with people who are high cost with serious illnesses. All right, that's where I'm going to stop. I'm here through Friday. Tip your waiters, try the meatloaf. I'm looking forward to the exchange.
Great panel.